All right, good morning, everyone. I'm Mike Schallmo. I'm one of the PGY3s, and I'm going to talk about ergonomics and orthopedic surgery. No disclosures. We all know orthopedic surgeons face a lot of physical stresses over the course of our day. Up to 2/3 may sustain at least one work-related injury during the course of their career. About a quarter of orthopedic surgeons will actually miss work because of an injury. Something like 3/4, maybe even more of these injuries don't even get reported. And 38% in one study, 38% of orthopedic surgeons said that they didn't have any institutional resources like referral to rehabilitation or disability benefits for their injury. And these may be career limiting or in some cases even career ending. Even in the general population, work-related injuries can lead to early retirement in about 8 to 28% of people. There was one study that I saw where around 10% of orthopedic surgeons, up to 10%, of orthopedic surgeons may have to retire earlier than expected because of a work-related injury. This was a study out of Vanderbilt. It was 140 orthopedic surgeons in Tennessee, and just kind of looking at who sustained a work-related injury, and it's about 40% across subspecialties. And about 36% of orthopedic surgeons said at some point their work has been impacted by an injury or by musculoskeletal pain. Orthopedic residents, definitely not immune. The vast majority of residents sustain musculoskeletal pain, sometimes even injury as a result of being in the OR. Arthroplasty attending, same thing. Vast majority sustain musculoskeletal pain as a result of being in the OR. And there was one study that looked at 12 different surgical specialties, not just orthopedics, and arthroplasty attendings actually spent the most time in risky ergonomic positions. So briefly, ergonomics is a buzzword we all hear a lot, but it's basically the study of people at work and is basically about designing the environment to suit the person, suit the worker, rather than everyone sort of adapting to their environment. And it involves things like safety, efficiency, effectiveness, and avoidance or elimination of risk factors, and is based on actual needs, not purely just comfort or what something looks like. And as we'll talk about, there's a lot of implications. So getting a little more specific here, within surgery, of course, we all know there's a lot of exposures we have in the operating room that put us at risk for various things. But specifically surgeons, there's physical demands of doing surgery. And so because of this, there's a risk of musculoskeletal pain and different injuries. And a big reason for this is that ORs are not optimized for us. So, for example, there's often a size mismatch, almost inevitably, whether it's your instruments don't really fit your hands, or if you're using foot pedals, you can't really put them in a position that allows you to be in a good position at the table and reach what you need to reach while also reaching the foot pedal, or the overhead lights are in an odd position. And then especially at places like ours, we have a lot of learners, the ORs get cramped very easily. And next thing you know, there's not much space for you to be in an optimal position during the case. OSHA actually has guidelines published specifically for the operating room pertaining to ergonomics. And there's some online tools that you can look at if you're curious. So this is sort of a depiction of something that we're not super unaccustomed to, just these sort of awkward postures that we find ourselves in sometimes, leaning over the table, looking at a deep dark hole for hours and hours. So what about orthopedics specifically? All of this stuff is all too familiar to all of us. There's a lot of equipment that we wear, lead, loops, headlamp. There's a lot of force that's needed to hold limbs, to reduce things, to position things, and sort of maintain limbs in certain alignment. Again, the size mismatch, perhaps orthopedics more than others. A lot of our instruments are big, bulky instruments that weren't necessarily designed for people either with smaller hands or to be used sort of efficiently. Long cases, we use power tools. And then there's difficult surgical approaches and awkward postures that we find ourselves in across the subspecialties. If you do arthroscopy, a lot of times you have a forward head posture, your shoulders and your arms are elevated. Not the best if you do microsurgery or spine surgery, you're using loops. A lot of times your head is down looking at the table for hours and hours. And then obesity is something certainly we're all familiar with. Our patients continue to get bigger and bigger, and it actually does pose a health risk to all of us when you're operating on people that are 400, 500, 600 pounds, and we're holding limbs, we're prepping limbs, or we're trying to reduce things or hold things for an extended period of time, and it puts a huge strain on us. So this is just me demonstrating one of the awkward postures that we often find ourselves in. And so briefly, before we go into some of the strategies for good ergonomics, it's, I think, helpful to just think about what are some of the barriers and things that make it challenging or make us resistant to implementing certain things. And I think the first thing is the resilience culture in surgery. So as surgeons, we endure a lot of hardship in our training and in our careers. And nobody wants to be seen as complaining or as weak or something like that. And, you know, it serves us well for the most part, but also kind of makes us susceptible to this mentality of pushing through things. And we just sort of say, you know, I'm going to grit my teeth and bear it. And, you know, that sort of mentality, I think, was for me, it was sort of my, what sort of inspired me to give this talk is, you know, I find myself a lot of times just kind of banging my head against the wall, like if I'm sore or hurting, and yet I don't really do a lot to change it. And I think that is probably something that's shared with others as well. Certainly there's costs associated with it, our own time, effort, our money, or the institution's money. And so because of these costs, we end up just sort of taking the path of least resistance and hoping that we'll eventually figure it out, or hopefully these things don't catch up with us before we retire. We're, as physicians, we're always kind of focused on other people. We don't really focus on ourselves. And even more practically, like during a case that's more complicated, or during a part of the case that you're more concentrating, you know, it's easy to sort of lose track of your posture and things that you may be doing that could be, you know, causing you to have pain and, you know, be hurting yourself. And then lastly, I think knowledge is another one. A lot of people aren't familiar with sort of specific recommendations and guidelines for certain things, or what things may put them at risk that they didn't necessarily even consider or didn't even know. You know, institutional commitment, we don't really get formal education about ergonomics, and there's a variety of reasons for that. And then, you know, there's also sort of some data limitations. A lot's been published on ergonomics, but you know, some of this is extrapolated from other non-medical fields, or, you know, maybe other surgical specialties, which isn't immediately applicable to orthopedics. So there's some limitations there. So I won't belabor this, but certainly having good ergonomics, you can imagine there's a lot of benefits for us as surgeons. There's benefits for our patients. And then it also benefits the development of new technology and techniques to, again, adapt the environment, make things more efficient, makes things easier for us, and improve upon previous designs. This was a study by Dr. Fram a couple years ago, and essentially this showed that difficulty with using instruments and discomfort with instruments increases as surgeon hand size decreases. And so because of data like this, companies are starting to develop smaller instruments and instruments that are have more mechanical advantage and things like that. You know, we have these like giant periarticular clamps, for example, and this is certainly not something that was designed to be used with one hand. And I'm pretty sure it was designed for somebody has an enormous hand, because these things are extremely cumbersome to use. So this is just sort of looking at some technology that's been designed with surgeons in mind. So these are surgeons that operate on the pelvis. So there's this operating chair that's used. This device attaches to your legs, actually allows you to sit in the operating room and takes weight off of your feet, but puts it onto your thighs and your shins. And then this is zero gravity lead, which is pretty cool. I think IR uses this a fair amount, but it basically is lead that comes down from the ceiling and takes the load off of you. All right, so some evidence-based strategies for good ergonomic practices. The first thing is just being aware of your posture. So that's starting with the most efficient position of the spine. We all know it's like shoulders in line with ears, shoulder blades back is what is sort of the most efficient position for your spine. In doing this, it minimizes fatigue, it decreases stress on certain body parts, and then decreases the risk of a variety of musculoskeletal issues. And there's really 5 major factors that will influence your posture. There's a few others as well, but the main things would be your table height. If you're using any sort of magnification, if you're using monitors, where are those positioned, the design of your instruments, and if you're using foot pedals, where those are positioned. So in the neutral position, your cervical spine has a weight of approximately 10 to 12 pounds from your head. But as you tilt your head forward, that load, the moment arm increases, and that load experienced by your cervical spine increases. And so you can imagine whether you're looking at your phone or you're, again, staring down in a deep, dark hole for hours and hours, that load on your cervical spine is going to be a lot higher. And if you add loops to this, if you add a headlamp to this, you know, the load goes up even more. It actually increases it by up to 40%. Using a combination of loops and a headlamp. So, and you know, for microsurgeons and certain subspecialties, they spend a lot of time with their head tilted quite a bit. So things to avoid, the forward head position is a big one. So avoiding neck flexion greater than about 15 to 20 degrees. This increases degenerative changes. And again, as I just said, it's exacerbated by wearing certain things like loops or a headlamp. Avoiding excessive neck bending and rotation, excessive trunk rotation. You know, even be mindful of your assistants, people helping you retract, or your scrub tech, making sure that they, as best you can within the limitations of the OR, making sure that people have good posture and they're not having to sort of hold awkward, contorted positions throughout the case. Avoiding prolonged kyphotic postures, stand close to the table. We all have a tendency to lean over the table and sort of, you know, again, moving our body rather than trying to move the table or adjust the position of the patient or something. And then be mindful of this throughout the procedure. Recognize that probably you're going to have to change the table height or change your body position at some point throughout the case. So if you know, find yourself like in this position, and you take a second, you're like, all right, what can I do differently here? Can I turn the table, or can we have positioned differently for the next case? Those are the sorts of things that'll help you. Table height, excuse me, there's several different factors to consider. In general, you want to be operating with your hands below your elbows. Most of the time, that's going to mean that the table should be around the level of the umbilicus or kind of just below the level of the elbows. Generally speaking, they talk about setting the table height to the height of the tallest team member so that everybody else, you know, needs to use a step, and then adjust it throughout the procedure. So if you're doing more precise work, then you want kind of the just below elbow height. If you're doing something more forceful, like you're doing infrapatellar nail for a tibia, and you know, you really have to get up high, try to lower the table as much as you can to get as much of that mechanical advantage. If you're using a microscope, you want the table above the level of the umbilicus. And again, loops, you kind of want the table just below or just at resting elbow height. And again, obesity can introduce a whole new variable to all this. And especially for some of these morbidly obese patients that are 400, 500, 600 pounds, you know, the best advice is either they need to be lower or you need to be higher somehow. And unfortunately, even then, there's still a likelihood you may have to be leaning over them just to get past their pannus or what have you. So this is just a depiction, the image A of what a good table height is and sort of a good working position versus image B, hunched over, leaning over the table, head is tilted forward, not good. Magnification. So a lot of subspecialties aren't using loops routinely, but just keep in mind that if you're having difficulty with your vision, the tendency is to lean forward and to tilt your head. And then, as we talked about, that can lead to pain and degenerative changes and things like that when we'll talk about some of these other ones. So this is comparing head and neck position with loops versus the naked eye. So the first image A is just the naked eye. So you can see a little bit of head tilt looking down at the table. When you put your loops on, that allows you to bring your head back into a little more neutral alignment compared to using the naked eye. And then if you're looking over your loops, like in image C, then that causes you to tilt your head forward even more. This was an interesting study looking at through lens loops versus flip up loops. And there's, two big advantages using the flip up loops. Number one is that you can see you have a little greater declination angle, so you can keep your head in a little more neutral position, and the loops are focused downward a little bit more. And then the other thing is that when you're done with them, you just have your assistant flip them up, and then you don't have to look over them in order to not, use them. And then these are loops with deflection prisms, so you can imagine even more so you can keep your head in a more neutral posture while you're working right in front of you without having to be staring down like that. This is looking at using loops in a headlamp versus a microscope, so kind of self-explanatory, but you can see when if your work is amenable to something like this, that if you use a microscope, it brings you to a little more neutral head position and also takes all that weight off of your head. The debate over, doing something open in MIS is sort of beyond the topic here, but the point is that it changes your head position and makes it more neutral. And then the exoscope, I think most of us are familiar with the Orbi, but for anybody who's not, it's essentially a camera that looks into the operative field, and then it displays it in real time on a big 4K 3D monitor. And the nice thing about that is everybody's looking at the same operative field. You have the same orientation. Not everybody is hunched over this tiny little hole to try and see in there. And it just can make it a lot easier on your assistants as well. I think we're all pretty comfortable with C-arm positioning for a lot of cases, but it's something that's worth a mention because, for example, if you're working on a lower extremity and it's the medial side, say like a medial plateau or a medial malleolus, it could be helpful to have the monitor come in from that same side, so like the right side for a right leg. If it comes in from the opposite side, then you're going to be kind of working underneath the C-arm, or you're going to be working from down at the foot and reaching. So trying to sort of anticipate things like that, thinking ahead of time so that your room is set up properly in an optimal way. And then your monitor position. This is sort of goes without saying, but you want your monitor kind of in a direct line of sight, not obstructed by anything, and kind of just below the level of your horizontal gaze. So this is Dr. Karnacher and I, and you can see we have two monitors there. One is the one that I'm looking at doing perfect circles, and then there's one right behind me that he can look at. And so, this way you're not in one of these situations where you're trying to do this fine, precise movement, and then every 5 seconds you keep going like this, and again, banging your head against the wall. So just an extra monitor can be helpful with something like that. This is at Mercy, so these are those monitors on the booms. Obviously, you can position these in a bunch of places that'll help you and your assistants out. You also have the cameras on the overhead light, so you can display that on these monitors or on the big monitor at the front of the room. Again, just to even make it easier on your assistants to see what's going on. And then a couple other things. So give some thought to patient positioning from an ergonomic standpoint. Always handle patients safely. And, I think a good example is like when you're flipping somebody prone, there's usually one of the OR techs or somebody is like the main person who's going to support their body and like hoist them up. And it always just makes me cringe that like you're essentially deadlifting something from in front of you. And some of these patients are absolutely massive. So we just have to be very careful. Minimize or eliminate manual lifting whenever possible. That could be like limb positioners to hold a limb while you're prepping it, or retractor holders or what have you. And then we talked a little bit about headlamps. Those have pluses and minuses. You can certainly have light when and where you need it, but it adds weight to your head. Position your overhead lights appropriately at the start of the case. And then just a couple other things to go through here. Things that I think most of us, if not all of us, have sort of seen. There's padded floor mats that people like to use, chairs, footstools, a variety of things that you can wear with your lead. Make sure that your lead fits snugly, and the waist belt puts the weight of the lead more on your pelvis rather than on your shoulders, which is important. A variety of different sort of surgeon factors. One of the things that gets talked about are these micro breaks, and essentially what some different studies I came across have shown is that cases going longer than about 2.5 to 3 hours, every 30 to 40 minutes, if you take a 30-second pause and just sort of range your neck and stretch your shoulders and roll your shoulders back, that helps with your energy, your stamina, your focus, helps to reduce pain. So something to just sort of think about. And then a variety of different technology, and again, sort of comparing the, what is better or more effective is sort of beyond the scope here, but just recognize that some of these things can be used to your advantage. And then finally, ergonomics education. So there's risk assessments, the rapid entire body assessment or rapid upper limb assessment are apps that are available for purchase. It takes a picture of you and then provides you some data on what your postures are, and it gives you like a grade and things like that. Just gentle reminders to OR staff and other surgeons if you see them, kind of in those awkward positions for extended periods of time, like, hey, stand up. I remember Dr. Masanis would tell me that, and Dr. Irwin would, sort of, have that effect on me of being more mindful of my position in the OR. Encourage good practices. If somebody brings an extra monitor in or puts a monitor in a little better position because that's what works for them, I think as long as it doesn't change the case too much, it's probably good to encourage that. And then, if, for example, if you're letting a resident operate, it's helpful to just put them in the driver's seat, make sure they're in the position that you would be in if you're operating. I know that can be tough sometimes because you're working back and forth, but if you're in an assistance position, but you're trying to operate, it makes it harder to visualize, you're in a weird posture, things like that to just be mindful of. This is that scorecard from one of those apps. It can just kind of gives you some of the subjective data. And so, good ergonomics is just like any skill, like being a discus thrower. This is the second throwing picture. I didn't think there would be two, but it requires structured and guided and deliberate practice on a daily basis to get good at it and to have it something that just becomes routine for you. So, we need to listen to our bodies. If they're hurting, we need to make sure we are taking some action and making changes and not just keep banging our heads against the wall, expecting different results when we don't do anything. This was a paper that we published recently. I think most of us are familiar with Dr. Shu's perfect surgical planning acronym. And I think, there's a strong case to include ergonomics in that and just be thoughtful of that before a case, especially longer cases or things where maybe it's not something you typically do. Make sure that the room is set up appropriately, that you have the equipment that you'll need, and try to give some thought to like, what am I going to do to address some of these anticipated issues? So in closing, developing your own approach. Again, we talked about posture, good postures, being aware of your posture, patient positioning and safe handling, a variety of tools at your disposal and different things, and then ergonomics education. So in closing, this is Kirk Karwoski. He's the world record holder in the squat. He squatted 1,003 pounds. And I think this quote really highlights the resilience culture in surgery, pushing through pain and being mentally tough at the cost of our own physical well-being. I hope that this talk helps us all to remember that our bodies definitely take a beating in surgery. And so we have to play the long game. So just be mindful of your bodies, take care of yourselves, and just as well as we take care of our patients. All right, thank you.
Mike, thanks. Very timely topic and really important. One of the things that I talked to a lot of you all about in the OR is a setup for a fluoroscopy for hand position on a shaver. And that, your foot pedal position and all those things are things that should be perfected before you get in the OR, so you know how to set it up. So the monitor position, hand position, if you wear less than a 7.5 glove, you need to use your thumb for the suction control. If you have a big hand, if you're an 8+, you can do it in a supine position and use your index and your long fingers for suction control. But that's something you got to play with in the lab before you get to the OR. It's not something to decide on game day. So I would encourage to take this one step further and say, if you're going to be doing microsurgery or you're going to be doing trauma surgery or whatever, think about this ahead of time so that you're not trying to work it out on game day.
Yeah, thank you. Dr. Waters.
Great talk. There's two things that are interesting to deal with folks in the room. So one is Andy Palmer, former president of the Hand Society, a smart guy, looked at degenerative arthritis in hand surgeons for how they wear their loops and their weight in their head and bringing it down. If you look at Chatterton's new loops, his head can stay up because his magnification goes straight down. It's a little eerie when you scrub with him because you think he's looking right at you all the time, but he's actually looking down, and that puts your head in a better position. It puts him at less risk over the course of his lifetime. And similarly, Dave Skaggs has looked at how you do drills and started to redesign drills because of the way spine surgeons, particularly as we've gone to every spine, every level needs 2 pedicle screws. You know, how to do that, how to modify the drill so that you're not in that weird position that you showed while you're trying to do it. So I do think we have to actively get involved in these things and redesign. Very, very good for you and Joe to think about this more.
Spinal navigation has helped my neck and spine surgery as much as anything, because I can just stare at a screen instead of down. That's been huge. But my neck always hurts.
Dr. Scannell?
Mike, I thought it was a great topic. And the biggest thing that I take away is longevity of doing this in my career. So there's lots of things that I do, and as I look at today and tomorrow with 2 massive spine cases, I'm tired at the end of the day. And you know, it's trying to make sure that we're positioning ourselves, in the OR. It's the exercise and staying in shape outside of the OR as well. But all of this that you presented today is just so important for me, for all of us, to be still doing this 15, 20 years later. But then I'm retired. I'm not.
Great.
I mean, you can talk about patient obesity, but don't forget doctor obesity as well.
Yeah.
You're too far away from that table. And well, not just obesity, I mean, pregnancy is a big deal. If you get pushed away from the table, not put you in a bad position. Like, operating pregnant is not hard enough, I would imagine. I clearly haven't been there, but add that ergonomically, that's not easy. So, I mean, this is a good example of a topic that you can't always be perfect. You can't always fix all these things. I mean, there's a lot of idealism in what you talked about.
Yeah.
But take away the sort of the educational points. Think about the little things, because, it's like I joked, you can take 1 X-ray instead of 2, you're getting half the X-ray exposure. If you can manage to just change a little something in each case, then you're going to improve, your longevity. Thanks, everyone.
Thank you.